Welcome to AiArthritis Voices 360. This is the official talk show for the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AiArthritis for short. My name is Tiffany Westrich-Robertson. I'm the CEO of the organization and also a person living with the diseases myself. So I am here today as one of the co-hosts. I'm joined by another fellow patient co-host and my rheumatologist, Al Kim. Woohoo! All right. So first and foremost, I'm going to turn it over to Deb to say hello.
Hi, everybody. I'm Deb Constien. I am tuning in from Madison, Wisconsin. And I was diagnosed with rheumatoid arthritis at the age of 13. So 40 years of having this lovely disease and lots of lived experiences going with it.
All right. Thanks, Deb. Deb is one of our recurring co-hosts, so you probably heard her on here several times with me before. And our guest of honor today, Al. Hey, Al.
Hey, Tiff.
I have a hard time, even calling a doctor
Al.
I know.
It took me a long time. If you listen to the older shows, like from 2 years ago, I always say Dr. Kim, and then it kind of went to Dr. Al, and then he just comes, it's just Al. Just say Al.
Because I behave like someone who deserves to be called Al. So anyway, that's also the name my mother gave me when I was born. So anyway, my name is Al Kim, and I'm an adult rheumatologist at Barnes-Jewish Hospital in St. Louis, Missouri, where I'm also on faculty at Washington University School of Medicine. I also founded and I co-direct the Lupus Center here at WashU. And Tiffany is indeed one of my patients. Some interesting things. We've had many good discussions, though.
We have
during our visits.
We have, and that tees me right up for the for the topic. So this is actually part two-part series here. It's a spinoff of our series called RheumyRounds, and RheumyRounds, if you've heard before, is actually co-created in part by Al, because I asked him, could you come and do like a pilot with me? We think it's a really good idea to have some episodes where rheumatologists and patients sort of come to the table as equals. And we talk about some things that might not be so easy to talk about to a doctor. And then together we sort of hash things out and then come up with solutions. And so in this particular episode, it's a part two to one that aired in December of 2022 with Dr. Lisa Zicker, and it's called The Good, the Bad, and the Ugly. Like saying it like that. So, which is going to be an ebook that AiArthritis is going to be putting out based on submissions of stories by both patients and rheumatologists about situations in the office setting where communications may have led to some really great outcomes and experiences, and maybe not such great outcomes and experiences. And I have to say, because I mentioned this before we started recording, Lisa was very, very in on the side of the good. We got a lot of good examples, and I said, I bet you I can get a couple from Al that he can share with us that maybe weren't so good. So there's a lot of pressure on you, Al.
No, it's not pressure. It's just baseline.
Okay. And now I'm kind of setting myself up because I am one of those patients. So I don't know. But I think we have.
He might be talking about you.
I know. I'm going to really be listening for that. But I feel like we have a lot of good examples of what happens in good experiences. So that's the topic today. And as a result, we are going to be encouraging all of you who are listening, who are people living with AiArthritis diseases or rheumatologists. We have a link for you to submit your experiences of what you think constitutes a good experience in the office, a bad, and just a really downright ugly, because we do have examples, and it's important to listen to all of them so that we can highlight some great examples of what to do, what not to do for both parties. And then we're going to work patients and rheumatologists together to create some recommendations of best practices based on those submissions. And see, you can be part of an ebook just for submitting your story. You be part of the project. So we're going to kick this right off with Miss Deb. Deb.
All
I
right.
feel like I'm a game show. Choose.
You kind of
like I got
that.
cards. Good,
Yeah, you've got that energy.
bad, or ugly. Which one would you like to do? Which would you like to share with us?
So I'm going to start with my ugly experience that I actually walked out of the appointment with my rheumatologist, and he got fired on the spot. It was a follow-up appointment. The doctor had, and he was new to me anyways, but he had asked if I wanted to go on a clinical trial. And mind you, I was actually doing well with where I was at with my medications and things like that. And he asked if I would go on a clinical trial. So I went home, talked to my husband about it, and came to the follow-up. And I told him, I don't think I want to poke the bear. I think I'm doing really well. I believe in clinical trials, but I don't think this is the right time for me to go digging around. He looked at me and he told me my husband must not love me enough to give me that recommendation. And I'm like, I think we're done. And I literally got up and grabbed my jacket and I walked out of the appointment. And I'm like, I can't keep going to this practice. I'm going to have to go to some other rheumatology clinic because I'm not even going to even venture the thought of meeting this guy in a hallway of another rheumatology. I was like, yep, I'm done. So that was my ugly.
Wow.
I think we're done.
Mic drop. Boom.
I know it was shocking to me because we really talked it over and really hashed it out with my husband, and he supported everything that I was like coming back with. And for him to say that, it was something.
Yeah.
It was something.
That's so if that was an example in the book, let's just pretend we're reading your story in the book. And, I think, before I say that, what do you think, Al? What is some of your recommendations on what might be better practice or communication?
I can't wait to hear this.
Simply put, the exact opposite of what happened. This is the old school example of how medicine used to be practiced as paternalistic kind of point of view, right? That the communication was unidirectional and in one direction from the physician to the patient. Yep. There's no room for negotiation. There's no, back when all this was happening, there was, there weren't really many lawsuits, malpractice type lawsuits, which kind of changed the game quite a bit, actually, good and bad. But at the same time, it's how do you just discount what you say? They might as well put a muzzle on you and just mandated a whole bunch of things for you and insult you and your husband, right? And so, that pretty much sums up that experience. I'm glad that you fired him on the spot. Every sane human would have done the same thing.
Yeah, I am not that kind of person that ever just makes a judgment call in the moment, because typically I think I would have been more shocked and probably sat there, but I didn't. I'm like, yeah, game over. We're done here.
Absolutely. I'll throw one out that is both. It started as an ugly, kind of a bad to an ugly, and then it turned out to be good. And so that was when I started in Los Angeles when I was originally diagnosed. Then I moved to Phoenix on my way back to St. Louis. And when I was in Phoenix, while I moved there, I had my diagnosis was rheumatoid arthritis. And at the time, I was on a medication indicated for rheumatoid arthritis exclusively. And I was really getting bad to the point where I could not get out of bed in the morning. It felt like my spine was glass. If I moved a half an inch, it would shatter. I was having to carry a bar stool around with me everywhere because I couldn't stand longer than a few minutes. I knew this was related somehow to my spine, to my lower spine. And at the time, I'll date this was 2013. And I had been tested for ankylosing spondylitis and I didn't match the criteria. So that didn't know what to do. So I get to this new rheumatologist in Phoenix, had visited, and they said, let's start over with some blood work and some x-rays and all, the whole new journey of trying to figure out what's going on with you. We're not convinced it's rheumatoid arthritis. And long story short, I go back to get the results, and it wasn't the rheumatologist I was meeting with. It was the physician's assistant. And she was going over the x-rays and the blood work and said, we just don't really see anything that's showing up. So we're going to go ahead and leave this as rheumatoid arthritis, and we're just going to keep continuing the treatment and see what happens. And that's when things got ugly on my part because I was not happy at all. I was in more pain than I ever had been even to this day. So up until that point. And I just kept saying, this is just not acceptable. I need you to listen to me, that something is going on that is not working with the medication that I'm currently on. So something has to change here. And I ended up just saying kind of, do you know who I am? I know all of these things because I'm friends with the Spondylitis Association of America. And so I started rattling off what they say and diagnostics and things. And she goes, I'll be right back. And she leaves for 5 minutes and the doctor comes in. So I would just really refuse to leave the office. So I kind of turned that ugly. But I just wasn't going to take that as the answer because I knew better. And not everybody can say things like, I'm friends with the Spondylitis Association, but it got her to listen. And the doctor came in and he sat down and he listened again. He looked over everything and he said, I just got back from EULAR and heard about a new disease called non-radiographic axial spondyloarthritis. And you tick all the boxes. And it turned into a good visit. And he put me on a new biologic that at that time was in clinical trials for that condition. And within weeks, 2 weeks, 3 weeks, it started working. And I was on that successfully for 6 years. So good example of, I think, a crescendo of that. So
I agree with you. Because again, what jumps out at me is you as a patient you spoke up for yourself and you just kept, re-acknowledging, okay, well, what I'm feeling is not normal and this treatment isn't working. So, standing up for yourself and actually, having backbone.
Yeah. And I should say, I fast forwarded it, but that conversation was at least 15 minutes of me.
I'm sure it was
saying, I'm telling you something's wrong before I went into, I know this is different because this is why. So
Right.
I just want to clarify. It wasn't like I just jumped to there.
Well, I'm sure you did.
A lot of back and
Yeah.
forth, and I'm not leaving. I was kind of standing my ground. So let me ask you, Al, hearing that story, have you, I don't know if you probably have because you are a very good communicator, but
my English is pretty good. It is.
I mean,
put it out there for
the
public to know.
You listen very well. And, I think I'm going to attest to that because I was very complex when I came to you and said, I still have things that are happening and I don't have any answers and I need help. And you were very quick to say, let's just try something.
Mm-hmm.
So what happens when you get patients who come in who are saying something's not working right here? This is just, I understand that I'm on something. No, everything's going haywire. Tell me what which I'm going to say is going to be a good example of communication,
Yeah.
because I just know it is because you're a doctor. So tell me about how that situation would go.
I think when I came up in training, we were still seeing a lot of patients that just said, okay, I don't know if I agree, but let's just roll with it. Certainly probably last 10 years or so, I would say the majority of our patients have really thrown their opinion into the ring. And I think this forces the providers to have to really acknowledge that open discussions are going to happen. If it's not happening, then something wrong is going on then, right? Because ultimately, at the end of the day, with you, Tiffany, is that you tried to open the discussion to the provider, but that particular provider already had the story and narrative built in her mind that she had to recite in order to in her mind treat you, right? And I think that's kind of the aspect of this, of active listening, all right? Not just listening, but listening with the intent that you're going to come up with an action plan based on what you said, even though it may not be fully relevant to the reason why you're there. Also, I think in rheumatology, we see this quite a bit more because there's so many quality of life issues living with chronic diseases, particularly those that are musculoskeletal with pain components, that no other physician really wants to handle a priori. And so as a result, many of the stories come to rheumatologists. And I do find it our responsibility to address those issues and also say, I have an avenue forward for you. It's not going to be me, but there's a colleague that I think that could help. Or to be able to say, I'm not really sure what we can do right now. But the thing is that, I keep reminding me of what's going on, and something will click, right? Maybe it's something you picked up at a conference or a discussion with a colleague. And I think that's something that particularly our generation, we're really good at is, almost every one of us texts each other, providers nationally and internationally, and also on Twitter, just, examining cases, just throwing ideas out there. It's much more of a fluid communication stream outside the office, but it does require that active listening. All right. And I think the other kind of nuance here was that you saw someone else other than the MD initially for that return visit. And I think this is where the MD failed to set expectations. All right, including how office settings will run, because this is very common now in the private practice world, where the MD sees the new patients because of experience and complexity. But once you cinch down the diagnosis, it's almost always other help, nurse practitioners, physician's assistants, whatever, that end up taking care of the follow-up visits. All right, largely especially if the patient's stable. And I don't think I don't know. I know there's some practices in the St. Louis area that really do a good job of painting that picture, but I know most of them don't. Right, and that's really strange to, I think, a lot of humans when they hear that.
My rheumatologist speaks directly like that and has that open communication, and also will say, now that we've gotten you to a stable point, let's have my nurse practitioner start to see you. And if at any time something starts going awry, I'll come back into the picture and I'll still keep following all your blood work and all your other things that are going on. That makes a huge difference.
Right. It does. And so it's just a matter of making sure there's an alignment of these expectations. And this goes into the much broader topic we could talk about later about setting expectations for treatment, right? And your health, which is a much more involved and complicated discussion. But even just the simple things, saying that, this is how we run things here, but I'm still involved type of thing. If you don't establish that confidence in the process, you're going to lose their trust.
Yeah, I just think that this alone just opened up a nice bullet point to build off of as we develop this book, is that the different people that you could be coming in contact with in these communications that can derail a little. In this case, if I had not been persistent, I could have walked out of there with a diagnosis continued of rheumatoid arthritis on the same treatment, and who knows what would have happened. But we have to remember that there are different models of the office and different people. So definitely something to think about there. Okay, Al. Oh, go ahead.
I got one question, Tiff.
Yeah.
Did for that follow-up visit, did you know you were going to be seeing a PA?
No.
Okay, so you fully intended to actually walk in and see that alone. It's not good.
Yeah, I mean, it's bad business. That's really just bad business. There's a huge assumption by that office that you're going to see us and you're going to enjoy your experience and get treated. But, obviously its execution is less than optimal.
Yeah. Right. Yeah. So, okay. So Al, you're up. Roll the dice. Good.
Where do I start?
Or ugly?
I think, I don't know. I can't, I can't think of an ugly situation.
Okay.
I'm sure there was. I just expunged.
We covered the ugly.
We're gone.
We'll do some bads, and they can really all go and get lumped into where I wasn't as effective as a listener. I'm not going to give specific examples, but there have been multiple times where I either phase out sometimes, or I just didn't fully understand the ask and I misinterpreted without clarifying. And this leads to just a hellhole of a pit that you have to try to dig out of in order to rebuild that trust. And I think, at the end of these clinics where all of a sudden it's like the last 2 or 3 patients of a day, this happens. Part of this is that our energy and our mood really has to match the intensity of the emotion of the ask, right? Yep. And this is a major source of burnout, along with dealing with electronic medical records, which is a separate topic.
Okay.
But for me, I'm either fortunate or whatever. I only see patients a half day a week because most of my work at WashU is in research. And so as a result, I can kind of emotionally just let it all out, right? But usually the rest of the day, I'm a bit of a zombie. Like I've given all I can. And so when I think of my colleagues who see patients 3, 4, even 5 full days a week, I don't understand how they manage their emotional reserve.
Their brain just can't handle anymore emotionally, right. And what you're investing into each patient, by the end of the day, you're done.
Right. I mean, I think not all physicians are empaths, first of all, but of those who are, keeping it up at a 9 or a 10 level out of 10 is a lot of work. But I think, I look at that the other way around, is that a lot of our patients that are coming in with issues that are 11 or 12 out of a 10 scale, they're living it 24/7. And I just have to turn it on and off during these visits, right? So it kind of tells me also that I kind of need to work on managing those emotions and those energies to make sure it's consistent and at the intensity that is required to make sure that many of the people that I see are equally satisfied with the care they're getting and confidence with the plan moving forward. That's something, again, I think I never would have thought this would have been an issue during training, but of course, during training, I was much more concerned about, am I making the right decision? Medically, I always want to make the right decision medically, but that's usually sometimes not the right decision in the real world. Right. And that's where, and that's where that active listening really is so critical. That it adds more than just subtle nuance. I mean, it can add just, a whole new layer of difference in how you're going to present options.
No, that's a great point. So tell me about what you think, Al, are some of the best, doesn't have to be specific examples, but what makes a very good experience? What, if you were going to create some bulleted recommendations for this ebook?
Good question.
I know, and I didn't even prep you for it, so I'm just going cold.
Yeah, and there's just gonna be silence, and the rest of this podcast is gonna be super awkward because of it.
I highly doubt that.
And again, a lot of this really is dependent on kind of the time pressures of that clinic session.
Yeah.
But the more organized the patient is, and we've talked about this in prior podcasts, and I've heard you guys talk about this in prior podcasts, telling patients, organize your thoughts, right? And try to bring a list in, or better yet, send the list through the electronic, medical record system, all right, that can prep the provider with, talking points so that there isn't, so at least there's, an ability for me to be able to say, I've looked at these and I can lump these into 3 major things. And I want to run through them, just double check whether or not this is consistent with the way you're thinking, right? Out of the list of, say, 20 things that are there, right? So that saves so much time, but it also addresses all 20 of those concerns. Right. And so we don't do a very good job of that in our clinic. We don't prep our patients to think like that. Right. And again, there's so much room for for improvement in how we care for our patients. But this would be probably one of the next steps that we would do, at least within our lupus center, is try to come up with these type of forums. I know the Lupus Foundation America has some stuff. The GlaxoSmithKline has some stuff through the programs through for their belimumab product. And so there are resources. We just need to do a better job of disseminating them, instructing our patients on how to best use them, and then actually using them, right? And so that really is probably the thing that I appreciate the most when you're busy, is that all of a sudden you're like, okay, I have 6 things I need to discuss. All right, 3 of them I have to discuss right now. The other 3, maybe we can, punt off to other things if we, it's usually more complicated than that. But that's kind of like the biggest win for me, is like, you have a list. Let's look at it.
Right? Has your patient ever sent something to you through the medical records? Has that ever happened? Because I never would have thought to do that, because I come with my list of things.
Do you mean the portal? The portal?
Yeah.
The portals, yeah. Only once, but we get it every once in a while, but it's usually like a dire situation that's emerging.
Oh, okay.
Yeah.
Okay.
Right. And
I was just curious, because I love that idea, because again, you in your brain can sit there and lump it together in how you discuss that in the amount of time you still have, because again, that's limited.
I think, when we, like in our research group, we'll use things like Slack, other things would be like Discord, right? Where, it's this asynchronous communication, right? That we kind of do a little bit in medicine, with phone calls in the past and portal messages, now. But I think, we don't use it to prep for a formal visit and trying to extract out as much value within a very limited amount of time, right? So that, I think, is something we just need to do a better job of just executing.
Deb, what do you think makes for a really good experience?
So
communication wise.
Yes. I'm going to give a shout out to my rheumatologist here in Madison, Christy Bartles. I figured you'd know her because again, she's in the research world as well.
So good. Yeah.
So every time I am at ACR, I always try to go and hop in on whatever she's participating in. And she, during appointments, will tell me what she's knee deep in as far as research goes. But she is fabulous, because she brings in this document. So as she's asking how things are going, she's filling in everything on this. It's a tear off sheet. So I get a copy and she keeps a copy. And it reminds her too. And as we're talking about things, she will write down, okay, so where I'm thinking is these might be the changes we might need to do. And we're going to do at least one of them, if not two. And then she always wants what my opinion is so it's complete, shared decision making. And she takes notes on everything that I'm saying, as far as what's better, what's not better, what parts are really inflamed. Because she still looks at my hands are a mess, so she'll still do all the documentation of everything. And I feel like I'm really listened to, because she's making eye contact when she can, but she's documenting everything. And I still go home with that torn off sheet, and she'll go into her little spiel about, okay, so this is what we're changing. And in the very bottom of the document, it's got what I need to do. So I'm walking away with, I know exactly what I'm going to be changing. And we're still working on the prednisone taper. So I'm down to 4 milligrams from 7, and she's still actively working on getting me off. But again, I'm 40 years into having steroids. So in my head, but I have been doing the taper, but once things start get a little wonky, I kind of stay where I'm at. And again, I'll go back, and I know back in January, we'll be talking about it again, as far as, okay, you're at 4, let's keep going. And she'll want to know what my opinion is and if I'm going to do it. Because that's one thing I think about from a rheumatologist perspective. You're giving these orders and you're assuming that these patients are taking their meds as they're supposed to. And the non-compliance. So, I mean, do you ever, I'm sure it comes out somehow in the discussion of, oh, by the way, I'm not taking my sulfasalazine anymore, or I'm not taking my steroid anymore, or, those type of things. Like, just got to wonder how that blows the rheumatologist's mind. And because you're assuming.
So that's such an interesting perspective. And I think you're probably right that most rheumatologists will look at the patient and being like, come on, right? But so we looked at this specifically in our lupus patients, and because in lupus we have a very high non-adherence rate, and it's closer to 60-70% if you look at hydroxychloroquine. And we asked the question why. We had a very talented team led by this guy, Jarek Leung, who got his master's in public health. Tiffany, you know him.
He's been on the show.
Yep, at SLU with Elizabeth Baker, and now he's getting his PhD in public health down in the Rollins School of Public Health in Emory with several people, including Sam Lim, who's another major lupus guy down at Emory Grady.
Wow.
So Jarek helped us look at this qualitatively through interviews, and that's kind of the technique he really is mastering. And what he found through these interviews was the main reason for intentional medication non-adherence was poor communication between the physician and the patient. All right, because right, and I think this works at several different levels. First of all, if we think back of when we were in school, the thought of taking a test right after a lecture is given is ludicrous, right? You'd be like, I'm only going to get like 10% of these questions right. But this is what we expect out of our patients in our clinic visits, right? We basically tell you, right? We basically tell you once, and maybe we'll give you some notes, all right, about a medication. But we really don't provide additional mechanisms for you to be able to understand it, internalize it, process it, right? And this is what we do with studying, right? Then you're ready to be able to address the question at hand. Do I take this medication or not? We have no infrastructure for that. All right. We try to achieve this in a 20-minute visit at the very end, where the first 15 minutes was data gathering, synthesis, clarification, And then the decision is made to give two options. One option is decided on. I mean, it's insane, right? The way we do these visits. So and I can share a link to this paper in the notes, but this is something that we is kind of embarrassing because these are my patients that he's largely interviewing, right? So I'm guilty of this. And actually, it's interesting. A lot of our lupus data, most of it's from our patients, and we're asking some very tough questions. And it's made me re-examine, like, what the hell am I doing here? Like, why, how did I get so blinded to the fact that I'm not doing things the right way? So this was one of those things that we need to do a better job of building communication methods, and we're talking plural, like it can't be just verbal, right, in the office. It's got to be other mechanisms. And so we've been working with Beth Baker at St. Louis University on trying to figure out how can we make a digital resource that can not only query and identify unmet needs in terms of, say, social support, but then how do you fill that back in, including informational support from the provider's team. All right. So again, we want to make it more of a conversation. A huge issue here is going to be a burden to the healthcare provider's team. All right. And how do we manage that load? I think there's a lot of questions about that. And I think a lot of physicians, if they're going to hear this, they're like, I need a break. Right. Everyone needs a break, no doubt. It's just, okay, there's got to be a way where we can make this not so burdensome, because this will make the visits less problematic.
Right.
If you want to use that word. Yeah. So. Right.
Well, you went ahead and answered the last question, or partially, so I'll answer it. You could add to it, but you delved into, I was going to say, some of the barriers, the biggest barriers to communication in different components. So you started touching on it. Is there anything else that you would add as far as, this is really a barrier?
Yeah, I think I can't remember who mentioned like simple things like eye contact. Oh, it was you, Deb, right?
Yeah.
It's just you know me, Tiffany, like, our visits, what I'm trying to achieve is, can we have a similar conversation if we were strangers at a bar? Right.
Yeah.
Wait, well, what did I say? Right. But that's kind of the intent. Is kind of like, it's going to be free flowing. It may be directionless for a bit of time, but at the same time, you're trying to get to just, a very comfortable stage where information is being transmitted back and forth. All right. We're trying to remove barriers. That's ultimately, at the end of the day, the biggest thing, because I am new to you as a patient. All right. And yet at the same time, I need to earn your trust almost immediately in order for you to give me the depth of information and the quality of information, including things that are going to be personal, in order to be able to get to the next step. And so, like, for me, I'm going to exercise my privilege as a man, because I think for women, this is much more difficult because of status and respect issues. In our part of the country is a problem for many of our female physicians. But like, I never wear my white coat. I don't even know where it is. I know I don't wear ties. Right. I'll even wear things like this to the clinic. I have kind of this pullover. Right. And largely is because I'm not at all interested in playing the game where I am the doctor and you are the patient. No, this is a conversation between two people, right, with two different skill sets and two different knowledge bases. I have a specific knowledge base that's much more generic and broad, right, for the many thousands of people with disease X. You have a knowledge base for your experience, all right, and somehow we have to bring everything together, all right. And so it's a lot harder for the patient to be able to relay that experience, I think, than it is for us to be able to relay information, right, of what we're thinking. Right. So that's, to me, the most important personal goal with each new patient, is to make sure that there's going to be no barriers. All right. I'm not going to judge you, because I frankly look at myself and think, my God, I got a lot of problems. Right. So, right. But that's kind of how I view it. Right. Is that, It's just, this is the way for us to just have that conversation at the bar. That's essentially it.
And disclaimer, at no time were there ever alcoholic beverages served in this doctor office bar.
Right. But it's been discussed.
Analogy only.
It's been discussed. Don't lie,
Analogy
Tiffany.
only.
We've discussed this.
That's true. That's true.
Yeah.
Okay. Well, we are going to wrap this conversation up because we want to encourage it to be continued by everyone who is listening. We put a lot of different subtopics of communication and how it works in a doctor's office on the table here. We talked about adherence. We talked about diagnosis. We talked about therapy. We talked about not being heard. We talked about barriers. There's so many different components to this, and we all have very varied stories and varied experiences. And we really do believe if we collect enough of these stories along the spectrum of what is good, what is bad, what is just not okay, then we can, like, circling back to Deb's clinical trial story and her poor husband, Tim, not loving her. Oh, poor Tim.
What a shame.
Under the bus. He got thrown under the bus.
He got thrown under the bus.
And never knew it.
Funny.
And then being able to work together to come up with some great examples and things that we can build on. So it is a joint effort. That did not even plan that pun, but it worked. So it's a joint effort between the rheumatologists and the patients, and we would love for everybody listening to be part of it. Very simple. Just submit your story. We'll share the link with you also in the text portions of this, but it is at aiarthritis.org/GBU. Good, bad, ugly. So it's very simple to find more information on this and a link to submit your story. You can submit as many as you'd like. And we are just looking forward to seeing where we could go with this to improve communication in the doctor's office. So I want to thank my co-host, Deb. Thank you so much for being here. And also, Al, I appreciate you taking the time out.
Pleasure's
as well.
all mine.
So Al, tell everyone where they could find you or follow you if you want. I know you do some great posts that I follow on Twitter.
Yeah.
What's your handle?
It's much more not safe for work on Twitter, but my handle is at Al H Kim, ALHKIM. And so if you follow me and a lot of the threads that I'm on, you'll also get hooked up with many of the rheumatologists who are really engaged in social media. And you'll be able to kind of see some of the debates and the issues that we're having internally. If you are in the St. Louis region, you can simply Google my name, Alfred Kim, and Washington University, and my faculty page will pop up, and there will be contact information there if you wanted to be seen, especially if you have or suspect to have lupus.
All right. So there you go. And then you can find us at AiArthritis on all of the social media. That's Twitter, Facebook, TikTok, Instagram. I can't even remember them all because I am not the hugest of social media peeps at our organization, but it is at AiArthritis and all of those handles. And you could also find all of the episodes for this at aiarthritis.org/talk show. And while there, if you want to hit the big red button that says donate, we certainly would appreciate it because it helps with us in the production of the show. So that is it. Everyone, please pull up a seat at the table, submit your stories, and together we can change the stories of tomorrow. Thank you all for joining in. Until next time.